Hi everyone, my name is Mark Bates. I'm a metabolic health coach, and this is another of my question and answer series. Topic is crossing the metabolic Rubicon from adipocyte buffers to drivers of disease. I think you'll find this fascinating. Okay, here's the question. You described this fascinating shift where adipocytes move from being buffers to drivers of disease. There's a specific moment in this progression where the body crosses a metabolic Rubicon. What are the earliest measurable indicators, both in lab work and physical examination, that tell you someone has crossed this threshold? And how long before clinical symptoms appear does this transition actually occur? You might be surprised how early it does. Okay, so what you're asking though is very profound. And it's an important question because it's one that sits at the heart of metabolic health coaching. See, because a lot of times how people come to me and say, "Oh, my doctor says I'm pretty good," but I can take one look at them and say, "Well, wait a minute, let's take a couple measurements or so because I think you're on the way to metabolic dysfunction, and if not already at some levels of metabolic dysfunction, and if you really want to be optimal, we need to start working on it right away." And people go, "But my doctor said I was good," because your doctor was relying on some very standard tests. Okay? The moment when adipocytes transition from buffering excess energy to driving systematic dysfunction is a quiet tipping point. It doesn't announce itself with major bodily symptoms. Okay? It usually occurs years, sometimes decades, before obvious clinical symptoms like obesity, diabetes, or heart disease emerge. So your doctor may not be seeing these things right away. Okay, so let's talk about some of the earliest measurable indicators you can. We'll look here at the lab work. These markers can indicate the metabolic Rubicon is being crossed well before diagnosis. Fasting insulin. This is the gold standard. Normally should be under 6. Early dysfunction is between 7 and 15. And if it gets above 15, you're well into full dysfunction, okay? For many people, this occurs 10 years before the glucose begins to rise. HOMO-IR, homeostatic model assessment of insulin resistance. Once again, the formula for this one, if you want to know, is fasting glucose times fasting insulin divided by 405. Okay, the optimal number is under 1. You cross the threshold between 1.5 and 2, and if you're above that, once again, you're already in full dysfunction, metabolic dysfunction. And the reason this is a good one is it integrates both your insulin and glucose levels to detect hidden insulin resistance. Okay? Triglyceride to HDL ratio. This is your TG divided by your HDL. Optimally, it should be under 1. Okay? Your HDL should be how much higher than your triglycerides. Early dysfunction is greater than 1.5, and you're at high risk once you hit 3. Okay? This reflects hepatic, that's liver insulin resistance, and ectopic fat spillover. It's a powerful proxy for metabolic derangement. Okay, GGT, gamma glutamyl transferase. Ideally, it's under 20. Early concerns if that shows up in the 30s to 40s. Why it matters: elevated GGT, even in the high normal range, signals hepatic oxidative stress and early fatty liver, often long before ALT, AST measurements of liver functions rise. Okay, very important. Okay, adiponectin. Low levels under 6 are ideal. Okay, signal adipocyte dysfunction. Low levels are bad. They signal adipocyte dysfunction. All right, high levels are good. Adiponectin should be high when insulin sensitivity is good. Low levels predict metabolic syndrome and type 2 diabetes. I had that one backwards. I apologize. Okay, high sensitivity. This is not on the chart. High sensitive CRP, HSCRP. Early concerns if it goes greater than 1. Chronic elevation, which is if it's over 1 multiple months in a row, and I like if you're starting to see some blood tests showing that you're getting into that range, okay, uh, on any of these tests, I like trying to get them monthly if at all possible. Chronic elevation suggests systematic inflammation driven by dysfunctional fat. Okay, physical examination. Once again, you can always uh, comment, and I will give you a chart that will provide all this information. Basically, it's simple. Women, if you're over 35 inches, men, if you're over 40 inches, even without weight gain, your waist tends to get larger because of the visceral fat accumulation. It's a direct marker of ectopic fat spillover. Okay? If you have what are called axonous nigrigans or nigrigans, okay? These are dark patches on your skin, velvety dark, often at the neck and underarms. This indicates hyperinsulinemia. Okay, some people don't see them, but if you get them, that's what they're there for. Early hypertension. Do take your blood pressure and do check it. If it's really high, especially if you don't have a sodium sensitivity or a kidney or renal failure issue, early blood pressure that's high is a sign. It's linked to insulin's effect on sodium retention and vascular tone. So once again, high blood pressure is not good. And if you eat meals and you feel fatigued, that's reactive hypoglycemia. Means you're reacting to being insulin resistant, and that's not good. Okay? Let's talk about this timeline of this tipping point. Okay. A lot of the studies, for example, Whitehall 2 or the Framingham studies show that insulin resistance and compensatory hyperinsulinemia occur 10 to 20 years before type 2 diabetes onset, right? By the time your fasting glucose is over 100 or your A1C is greater than 5.7, which is normally when doctors get concerned, you've got years of metabolic damage already accumulating. Once your fat cells are already rejecting excess lipid and ectopic disposition has begun, you are definitely in metabolic dysfunction. Okay? So, you got some markers to look at, got some things to check for. Keep that in mind. So, putting it together real quick, the tipping point is fasting insulin needs to be under 6, 7-15 is bad, over 15 full dysfunction. HOMO-IR under 1 is good. Greater than 1.5 is bad. You're looking at you're starting to have problems. Greater than 2.5, you're there. Your triglycerides to HDL ratio, once again, you want that to be under 1. Greater than 1.5 is a warning light, and over 3 is definitely you're having metabolic dysfunction. GGT less than 20 is good, right? If you're over 30, it's a big warning light, and then greater than 50 is definitely you're in full dysfunction. Okay? Adiponectin, you want it to be ideally over 10. If it's under 6, that's showing some earlier problems. Under 4, you've got full metabolic dysfunction. Okay? And your waist circumference. For women, 35 inches. For men, 40 inches. If you're approaching that threshold, start thinking about this. If you're already at that level or higher, you have visceral fat if nothing else, and it's showing up. So you gotta be careful with that. Okay, a key takeaway. The metabolic Rubicon is biochemical and not necessarily visible. It happens at the cellular level. By the time someone has high blood sugar or gains visible weight, they've likely spent years in silent dysfunction, with fat cells inflamed, mitochondria impaired, and glucose disposal failing behind the scenes. Catching this early is not just possible, it's essential. It's where ketogenic and carnivore interventions can reverse course before irreversible damage sets in. Okay, just keep this in mind. By the time someone has high blood sugar or gains visible weight, they've likely spent years in silent dysfunction, with fat cells inflamed, mitochondria impaired, and glucose disposal failing behind the scenes. If you're in that boat, think about how you're going to fix your metabolic health. Okay? I want to thank everyone for watching. If you have any comments, please leave them in the appropriate section. Any questions, put them there. If you have an idea for another video, go ahead and let me know. And please, if you haven't done so, like, subscribe, and share this if you would. It helps the channel a great deal. Thank you.